already here, and their time is valuable. So we'll go ahead and get started, please. And so, good morning, good afternoon, or good evening, wherever you are in the world. I am Bruce Oviagale. I'm president of the Society for Equity Neuroscience, or SEQUINS. And on behalf of the Society, I would like to welcome you all to this SEQUINS webinar, or SEQUIN as we call it, which is part of our State of the Science lecture series. Today marks our very first lecture. I'm delighted and honored that we have as our very first speaker an outstanding and internationally renowned clinical neuroscientist who just happens to be a close collaborator, friend, and colleague of mine. He's none other than Professor Mayowa Owolabi. Professor Owolabi is currently Professor of Medicine and Director of the Center for Genomic and Precision Medicine at the University of Ibadan in Nigeria. He previously served as the Dean of Clinical Sciences at the same institution. Professor Owolabi is an elected Fellow of the American Neurological Association, the American Academy of Neurology, the American Heart Association, the American African Academy of Sciences, and the World Academy of Sciences. He's a member of the World Health Organization Technical Advisory Group on Mental Health, Brain Health, and Substance Use. Professor Owolabi has over 460 publications, over 208,000 citations, and has a Google Scholar Age Index of 110. He's ranked amongst the top 2% of scientists globally and was the most highly cited Nigerian biomedical researcher from 2021 to 2025. He was the recipient of the 2021 World Stroke Organization Global Award for outstanding contribution to clinical stroke research, and very well deserved. If that wasn't enough, he co-chaired the Lancet Commission on Stroke, and also is currently the chair of the Lancet Commission on Neurorehabilitation. His US NIH-funded research work has greatly expanded our knowledge about clinical, socio-environmental, and genomic risk factors for stroke in West Africa. Today, Professor Owolabi will be giving a talk entitled Shining as SEQUINS, Lighting the Path to Reduce Service and Evidence Gaps for Improving Brain Health Globally. We will invite questions at the end of the lecture. Over to you, Professor Owolabi, and thank you.
Thank you very much, Bruce, for that very, very generous introduction. I think it's a very, very rare honor and a great privilege to be the first to give this State of Science lecture titled Shining as SEQUINS. It's actually a tour de force of what I've been able to do in collaboration with your humble self. And this is really a very, very great privilege, and I don't really take it lightly. So I'm going to be talking about lighting the path to reduce service and evidence gaps for improving brain health globally. So why is brain health important? It's because neurological disorders are the leading cause of disability-adjusted life years globally, accounting for, in fact, up to 18% of all cause deaths. And indeed, 43.1% of the entire global population, which is more than 1 out of every 3 individuals, are affected by neurological disorders. And nearly everyone has a lifetime risk of neurological disorder. So that is why brain health has become such a very, very important topic. Apart from the fact that all of us have brains, and the brain is really the ruler of the body, so to speak. Now, talking about burden of disease, we all know that NCDs is now receiving attention. 70% of all deaths are due to NCDs globally. And among the NCDs, the fastest growing cause of death are actually neurological conditions. This is not surprising because stroke alone is the second leading cause of death globally, and of course among NCDs. Not only are these conditions taking a toll in terms of being a leading cause of death and disability, they are also indeed accounting for humongous economic costs. For stroke, is almost up to $1 trillion per annum as at 2017. For dementia, about $1.3 trillion as at 2019. What are the top conditions responsible for these DALYs? There are 37 conditions using GBD data responsible for most of this. On top of that, of course, is stroke. The top 10 are stroke, neonatal encephalopathy, migraine, dementia, diabetic neuropathy, meningitis, epilepsy, preterm death, BATS, autism, spectrum disorder, and nervous system cancers. Across the life course, initially, it is neonatal encephalopathy, obviously. In the teenage years and early adulthood, migraine, and this is immediately overtaken by stroke and eventually by dementia towards the end of life. The major burden of these conditions are borne by low and middle income countries. That was the case in 1990, and that still remains the case in 2019, where more than 80% of the burden are borne by LMICs, predominantly in Africa and Asia, as you can see here. Sub-Saharan Africa, Asia. There has been a few changes in terms of the ranking, but stroke remains on top over the decades, followed by neonatal encephalopathy, migraine, headache disorders, and Alzheimer's have moved up a bit. Looking at stroke alone, just to give us an idea of the body, right now, over 100 million people are living with stroke and the aftermath of stroke. 147 million healthy years of lives are lost to stroke every year, and 1 in 4 people over the age of 25 have a lifetime risk of stroke. By the way, 90% of all strokes are preventable. And that is one of the things I'm going to be highlighting in this lecture. Up to 12 million new strokes occur each year. Projecting, this is from the Lancet Commission on Stroke, to 2050, and looking at the burden across different age groups and different regions, you will again see that Sub-Saharan Africa, Latin America, Caribbean, South Asia, the burden continues to rise. For all of stroke, for ischemic stroke, for hemorrhagic stroke. And stroke in the young is becoming a huge burden, particularly in low and middle income countries. And we'll talk about the reasons for this. In fact, recently, about 2 months ago, I managed a patient who at the age of 18 already had stroke, secondary school student at the age of 18, stroke from hypertension, not from any other condition apart from just hypertension that was undetected and undiagnosed at the age of 18. So it is projected that the burden will continue to increase in terms of deaths up to 2050 if nothing drastically is done. Mortality will increase by about 46%, DALYs by about 31%. And of course, also the costs will increase to almost 1.6 trillion by 2050. Now, I've given some of the background for why there is a brain health revolution. Is the leading cause of DALYs across the globe, more than 18%. Stroke is now classified as a nervous system condition, and so that also increases the burden attributable to neurological disorders in the International Classification of Diseases. The current economy is a brain economy. So where brain health really is very important, and I'm going to be talking more about brain health, brain skills, and brain economy. And that's why our brains really are the most important part of us. So in the past, we've witnessed agricultural, industrial, information revolutions. Right now, there is an AI revolution, but more importantly, a neurology revolution, which is concerned about improving human being and welfare through improvement of brain health. So there's a small piece in the Lancet on the neurology revolution, which will provide you with more details about this. Defining brain health, there have been a lot of definitions. but we proposed this, and this was published in Nature. Brain health is the complete functioning of the brain across the life course to support the full physical, mental, social, and spiritual well-being and quality of life of an individual towards attaining and maintaining the epitome of a meaningful, impactful, purposeful, and productive life. So brain health is really at the center of having a meaningful, productive, and purposeful life, at the very center of our well-being and our quality of life. And so it's important to think about brain health, not in terms of neurological disorders per se, but in terms of protecting and promoting our brain health and not waiting for brain disorders to occur. And of course, enhancing and improving our brain reserve, which is called eumentia. But more importantly, even seeing how we can improve our brain function in terms of supermentia. So some of these uh, elements that have propelled the neurology revolution gained momentum after the launching of the WHO Intersectoral Global Action Plan against epilepsy and other neurological disorders in 2022, which was supported by more than 200 countries, initially championed by Ghana and a European country. The essence of this is to bring to the fore prioritization and governance, advocacy, policy plans and legislation and financing to improve brain health, improve diagnosis, treatment and care, promotion and prevention, research, innovation and information systems, public health approach to epilepsy. There are 10 global targets, and which are elements of the 5 action items objectives I've mentioned. These are all proposed and supported by the member states and the WHO Secretariat, and are actions going on for implementation across the different WHO world regions, including in Africa, where the domestication plan, which we participated in and co-led with the WHO, is going to be launched very soon, covering 47 countries in Africa. So the Intersectoral Global Action Plan envisions a world where brain health is valued, promoted, protected across the entire life course, where neurological disorders are prevented, diagnosed, and treated, and where stigma is reduced, the impact of stigma is reduced, and quality of life of people with neurological disorders and their carers and families are improved and protected. In this publication in Lancet, we articulated how this can be achieved so that the benefits of the IGAP can be reaped by ensuring that an appropriate IGAP framework is implemented, supporting the different strategic drivers, including universal community awareness, integrated neurology approaches, intersectoral governance, regionally coordinated domestication, part of which I just mentioned, neurology mainstreaming, putting neurological conditions at the very center of the human health and social services activities, and lived experience informed policy. Universal health coverage and primary health care is very important if we are going to reach everybody, because brain health is everybody's business. And the integration across the entire care continuum, promotion, prevention, diagnosis, treatment, and rehabilitation is very important. Integrating within the NCD paradigm, mental health, social determinants paradigm, and commercial determinants, very important. And paying attention to all the major neurological conditions that have been mentioned. Some of these are synthesized in the Global Synergistic Actions to Improve Brain Health for Human Development publication, which involved about 40 neurology associations across the globe. The essence of this is to put brain health at the center of all the SDGs. Without brain health, there is no health, and without health, there is no SDG. Brain health is at the very center that powers physical and mental health, social health, planetary health, and is underscored by good and proper spiritual well-being. So we then need to think about the gaps, the knowledge gap, the standard gap, the delivery gap, the communication gap, the satisfaction gap that needs to be bridged. Across the four pillars, surveillance, prevention, acute care, rehabilitation, and the core of the neurological quadrangle, at the system level, one of the major challenges, of course, is inadequate prioritization of neurological disorders and brain health, high prevalence of unhealthy diets, and lifestyle factors that are potentially detrimental to neurological health. And these are increasing in low and middle income countries, and that is why an 18-year-old can have hypertension and have a stroke at that age from a low and middle income country like Nigeria. Acute care, unavailability of emergency services, and of course, also inadequate rehabilitation facilities and the lack of trained therapists and brain drain. Provider level, poor awareness, patient and community level, lack of awareness, inadequate training, cultural issues. These are all very, very important. What do we want to protect? We want to protect brain health, and we know that this is powered by ensuring that the brain economy, brain skills are all together helping to improve our well-being as well as our economic well-being uh, globally. So it's important to protect and promote brain health. To do this, we need to understand the biomedical factors, the political factors, the social factors, the psychosocial factors, the psychological factors, economic factors, commercial factors, environmental factors across the life course. And that, in essence, really means that we need to follow people up in cohort studies before birth all the way to death to be able to identify and unravel these factors and then target them for prevention and promotion. Holistic and socio-ecological approach is necessary. Life course approach, all of government and all of society, synergistic intersectoral approach is very important. So again, talking about human intelligence and supermentia. Human intelligence has different dimensions: linguistic, logical, spatial, musical, bodily, interpersonal, emotional, naturalistic, collaborative, creative, existential, and so on and so forth. We want to promote all of this. And to be able to enhance this, we need to look at the biological, unravel the biological factors, the man-machine factors, the social, cultural factors, transcendental factors, physical, mental, and environmental factors to attain improved human intelligence globally. In as much as we are trying to improve machine and artificial intelligence, and also supermentia. So this is going to be made possible through the neurology revolution. Using technology, artificial intelligence, human brain project, regenerative medicine, human affectome, human connectome, neurotechnologies, brain computer interfaces, but also looking at humanities, medical humanities, neurohumanities, neurolinguistics, neuropsychology, neuroethics, and so on. And leveraging existing initiatives like the One Health, Brain Health, the WHO Intersectoral Global Action Plan, the Rehabilitation 2030 of the WHO, and other initiatives, including the NCD, which is going to be launched, the NCD program, which is going to be launched at the United Nations General Assembly just a few weeks from now. So artificial intelligence is gaining relevance. How may it help us to achieve this? Artificial intelligence in the context of neurology can be useful, uh, but of course it has to be powered by data, which has to be used to develop models. Those models also have to be validated before they can be thrown into limelight or into the practice for prevention, for early detection, for treatment, for management, for brain health promotion. So foundational models, physics-informed AIs, computational omics, requiring multi-omics data sets, virtual brains, all of these are AI techniques that can be used, but the data required will include clinically collected data. This is going to be made possible with electronic medical records, large data sets. Of course, ethical hurdles have to be overcome for that to happen. Biosensors like accelerometers and wearables, which can provide a lot of information, including human mobility information, medical images, neuroimaging biomarkers, and brain-computer interfaces. So generative AI can improve brain health if we are able to help, if we have data, that can help improve the precision of results, diagnosis, analysis, and decision support tools for clinicians. Of course, this has to be regulated. How has this fared on the African continent for NCDs, cardiovascular diseases, and stroke in particular? How has AI and use of data science fared? Uh, we looked at this, we conducted a systematic review and data gap analysis. You will see there's a lot of data gap and for use of data science for cardiovascular diseases, particularly stroke, for surveillance, for prevention, and for rehabilitation. A little bit of that is used for risk prediction, imaging use for biomarkers, but a lot needs to be done for this to help with surveillance, for improving diagnosis, for prevention and rehabilitation. Now, many of these are not yet being used in the real world because they need to be validated and they need to be subjected to clinical trials. So a lot still needs to be done in ensuring that AI and data science can help improve neurological conditions and brain health on the African continent. So there are 4 major pillars: surveillance, prevention and promotion, treatment and acute care, rehabilitation, and palliative care. So applying this to stroke on the global landscape through the Lancet Commission on Stroke, I met this gentleman in the WHO in 2016, and we felt that very little attention was being given to stroke, whereas conditions such as HIV have big buildings, even at the WHO Secretariat, and a lot of attention. And up till now, actually, there is still no desk dedicated to stroke in the WHO. So we came up with the idea of the Lancet Commission, and we eventually developed pragmatic solutions to reduce the global burden of stroke through the commission. Again, across the 4 pillars which I had mentioned, we synthesized pragmatic solutions, having considered situation now gap analysis of the burden of disease, of the evidence of interventions that are already proven to be effective, prioritizing recommendations based on these evidence-based interventions and converting them into pragmatic solutions by analyzing the political, legal, ethical, anthropological, and socioeconomical barriers and facilitators. Of course, eventually synthesizing the pragmatic solutions. Looking at state of services, we will see that across the globe, particularly for rehabilitation pillar, and for low and middle income countries and sub-Saharan Africa, it is abysmal and actually suboptimal. And then guidelines alone are not the answers, as we can see. Even though some of them are rigorous, particularly in high-income countries, they do not cover surveillance and they do not pay sufficient attention to implementation plans and translatability. So we try to address some of these in the Lancet Commission on Stroke by looking at how to place proof in pragmatism and considering implementation science frameworks that will not only ensure capability and opportunity, but also motivation. There's not only looking at guidelines, but also looking at physical opportunity, societal and social opportunity, enablement, legislation, environmental and social planning, regulation, marketing strategies, communication, and so on and so forth. We analyze barriers and facilitators across several WHO region countries to unravel the barriers for service provision, workforce, information system, technology and supply, finance, and governance. And based on this, we then came up with recommendations, the sources of those recommendations, the level of evidence of those recommendations, the resources required for implementation, the political, legal, ethical, socio-ecological, cultural and economic considerations, which we call the PLEASE considerations, and eventually the recommendations for implementations. The key recommendations to improve surveillance, of course, includes using data, electronic tools, data science tools, improving rehabilitation by promoting multidisciplinary therapy, adapting evidence-based rehabilitations, interventions that are locally relevant, prevention by identifying the risk factors and using mobile and digital technology to raise awareness. Like we said, 90% is preventable. Improving acute care through effective plans for acute care services and stroke care networks, and strengthening the ecosystems that we proposed. For acute care, ensuring minimum stroke service across the globe, and essential and advanced stroke centers in as many places as possible. And primary prevention is very, very important, targeting the leading risk factors. Now, for Africa, stroke is the leading cause of death among neurological conditions. And working with Bruce and several others, we've tried to look at this, identify what the key risk factors are, which is in display, and how this can be targeted. And one of the intriguing findings was that daily consumption of green leafy vegetable has a dose-response protective relationship against stroke severity, against stroke fatality among Africans. For hypertension, it is better not to have hypertension because uncontrolled hypertension, undiagnosed hypertension, and in fact, even controlled hypertension pose risk for stroke on the continent of Africa. Of course, the greatest risk is for those who have uncontrolled hypertension or for those who are not diagnosed. Low vegetable consumption doubles the odds of stroke among those who are hypertensive. So we found that green leafy vegetable protected against stroke, different types of stroke, stroke in the young, stroke in the elderly, males, females, and against different stroke risk factors. And they had a dose response protective effect against hypertension, such that those who consumed at least 12 servings of green leafy vegetable were unlikely to develop stroke. We compared risk factors for stroke among African Americans and Americans of European descent in the REGARD study. We found that hypertension was more prominent among Africans, as is diabetes mellitus. We also compared risk factors for hemorrhagic stroke among Africans with African Americans, Hispanic Americans, and white Americans in the ERISH study. And you find out that there is interplay of racial and geographic factors. While some factors like hypertension cuts across, some add different effect sizes and directions, and this needs to be further unraveled through genetic and environmental studies. So, peculiarities of stroke among Africans: relatively higher proportion of ICH, about 34%, compared to about 9% in other places, and higher genetic heritability, which means we need to explore the genetic risk factors. And indeed, we've done this to some extent. We were the first to unravel the association between apolipoprotein L1 and small vessel disease stroke. And we also conducted the first GWAS of stroke on the continent and found genome-wide association for SNPs on, with loci on chromosome 3 and suggestive loci on other chromosomes. And these were loci near the A-DAC gene in chromosome 3 and microRNA in chromosome 5. And we conducted circuit that showed interaction between these genes and other genes, and tissue gene expression in brain and vascular tissue. So these novel SNPs suggest epigenetic interactions, regulatory activities, which are protective against stroke, and these are potential drug targets for drug development. MicroRNAs are gaining prominence, and the 2024 Nobel Prize in Physiology and Medicine was actually for the discovery of microRNAs. Polygenic risk scores are important, but they have to be developed using African data sets. Some preliminary findings looking at the proteomics, we found some biomarkers that are down-regulated and some that are up-regulated for stroke severity on the continent of Africa, and also for disability, 1-month disability. We are currently looking at metabolomics and proteogenomics and also multiomics, which is going to help us unravel the risk factors for ischemic stroke. Hemorrhagic stroke, we have not explored in terms of genetics. We are also looking towards obtaining funding to be able to do this. To summarize, to prevent stroke, we need not only look at the risk factors that we are familiar with, like hypertension, obesity, pre-diabetes, dyslipidemia. We need to take a step backwards and look at the political, legal, anthropological, socioeconomic factors, non-modifiable factors like genetic factors, which can also be targeted while we're preventing the modifiable risk factors and behavioral factors. And so primordial prevention, primary prevention are all extremely important, not just secondary prevention. And this is actually possible at government level. There is a policy which has helped, a brain health policy and vascular health control policy in Norway, which helped to substantially reduce the burden of ischemic stroke as well as stroke by more than 35% over a few decades. Now, for the TRIBE study, this is secondary prevention, the first clinical trial for secondary prevention for stroke in Africa. We had positive effect, but this happened both in the control as well as in the cases. And based on our findings in the siren, we came up with a manual and a stroke prevention bill and a Afrocentric stroke risk calculator combined with a stroke prevention video, which has in a pilot trial been shown to reduce the overall risk of stroke and improve blood pressure control. We are planning for a bigger trial to explore this. Overall, what is required is biobanks and longitudinal epidemiological ecosystem to look at brain health across the life course using a quadruple health approach. So we've started a population cohort, urban and rural setting, to begin looking at this in Nigeria with over 100,000 people. And some preliminary findings shows using spatial epidemiological tools shows some predictors of hypertension in the population. We found acoustic pollution to be one of the predictors, both in the urban as well as the rural setting. Hypertension is the elephant in the room, as we know. This has just been published in Cardiovascular Research. This is the Journal of the European Society of Cardiology. We looked at the prevalence and burden of hypertension in the last 2 decades in Africa. Indeed, up to 46% of adults older than 25 years are hypertensive. And when you use the 130/80 cutoff, more than half. And what is alarming is that only 93% are only 7% are controlled, 93% are not controlled. And that's really very alarming. So we came up with the Achieve ecosystem with the 80/80/80 target to ensure that 80% of those who are hypertensive are diagnosed, 80% of those who are diagnosed are on treatment, and 80% of those who are on treatment are controlled. So we came up with a 12-point communique after setting up the Achieve ecosystem with the support of all the different stakeholders, including Resolve to Save Lives, including World Stroke Organization, including African governments, and including World Health Organization. This was at the inception, attended in person by the Minister of Health for Ghana for 2 days. And also, we also propagated this at the NCD Forum in Senegal recently, and of course at the African Stroke Organization conferences. Now I'm going to talk about our efforts on the 4th pillar of the neurology quadrangle, which is pragmatic solutions for improving the quality of life of people with neurological conditions globally through neurorehabilitation. And this has implications for 3.4 billion people living with neurological disorders across the globe. Our intention is to add years to life, but beyond that, add life to years, meaning to life, and ensure that people are able to realize their purpose in life, feel their purpose in life. Patient, of course, is at the peak, he is king. We set goals working with caregivers and therapists, and we have a multidisciplinary approach to ensure that all the different uh, deficits or impairments of the individual are taken care of. So multidimensional characterization of the life course are part of the research priorities. Our intention, of course, is to ensure that people have access to multidisciplinary rehabilitation services, innovative low-cost interventions, training of rehabilitation potential professionals, and telemedicine and digital channels. Validation of the effectiveness of educational tools are all very important. Purpose of life is important, and neurohumanities is important in neurorehabilitation, as it can mitigate the pathological effects of conditions such as Alzheimer's disease. So we look at neuroplasticity and adaptive mechanisms for recovery and for rehabilitation using holistic models like the Seed of Life model, and improving quality of life, also using holistic models that looks at the entirety of the human being, including neurohumanities and neurospirituality. We find using an holistic related quality of life measure that, which is cross-culturally validated, that the soul and spiritual or the neurohumanities section or sphere of quality of life is preserved after stroke, while the physical, psycho-emotional, and cognitive aspects are the most affected. And so this could serve as a springboard to help recovery. This is part of what we are trying to study and unravel. We're also looking at new technologies like neuroimplants, neurorobotics, brain-computer interfaces, brain-computer spine interface, which can actually bring back the prospects of walking again or talking again or full recovery for patients who have suffered neurological injuries. And this usually happens when you use a bidirectional BCI that lands from the brain and adjusts to help improve functioning. Virtual reality, augmented reality is also helping. Human Affectome project help us to understand about human emotion and how this can be leveraged to improve recovery and motivation during recovery. The Human Brain Project helps us to understand more of the human neuroanatomy beyond what we knew before, beyond the Brodmann's area. And this can help facilitate brain-computer interfaces. Stem cell therapies hold the promise of helping with recovery, even though stem cell transplantation has not been so helpful, but they may help with neuroplasticity. Medical humanities, neuroscience, neurophilosophy are all very important. Neuromusicology, neurolinguistics. Neuromusicology has been shown to help with speech recovery as well as motor recovery after stroke. Heart is very important for expression. And there are patients who have not recovered from stroke in terms of their voice, but are turned to big musicians, and there are examples of these in Brazil. So spiritual psychology is also important. At the end, we want people who have suffered neurological injury to achieve ikigai, which is basically the Japanese word for coherence and convergence of passion, mission, profession, vocation, what the world needs, what they are good at and what they can do, and what they love doing, so that in the end, they can live a purposeful and meaningful life. So we are adopting a strategy to help achieve this across the globe for the 3.4 billion people by starting with a situational and gap analysis, which is currently ongoing, looking at the burden of disease, of neurological conditions, projecting to 2050, working with WHO and the Global Burden of Disease group, looking at evidence-based recommendations and evidence-based interventions from RCTs, prioritizing those interventions, using implementation science framework and coming up eventually with pragmatic solutions, including an economic case and policy brief and costs of interventions and non-intervention, and modeling this using GBD tools. So we've started this, and our inception hybrid meeting happened in April, and we have more than 12 working groups that are already rigorously and aggressively looking at this. And eventually we intend to disseminate this like we did for the Lancet Commission on stroke across different fora. So concluding, to improve brain health across the globe, we need to ensure that people have access to therapies. We need to come up with research ideas and research initiatives that are able to bring new solutions, including even what is thought not to be curable, new solutions that can actually help to provide cure, prevention, and recovery for neurological conditions, enlightenment, which is very important to inform, to inspire, and to involve everyone in improving their brain, promoting brain health, and also preventing neurological disorders and promoting recovery. Advocacy across all the different players and stakeholders, including intergovernmental agencies, WHO, and so on and so forth. And of course, SEQUINS is promoting this. All of these pillars of treat, and then training, including the SEQUINA that we are having today. We have to join hands together. If we want to go far, we really need to work together and not just go alone. We need to join hands together, working with global ecosystems that are intersectoral, that is not only looking at policymakers and providers, but looking at patients, payers, general population, the public, and of course, intergovernmental organizations and implementation partners such as SEQUINS and the different commissioners. Then we also need to soar with wings across the biophysical as well as the psycho-spiritual wings, using technologies, but also not forgetting neurohumanities, as has been mentioned before. And we need to let all the 4 pillars shine as SEQUINS to improve surveillance and innovation, improve prevention and promotion, improve treatment and acute care, improve rehabilitation, and chronic and palliative care. I want to mention some of the efforts that Bruce and I are trying to promote on the African continent and beyond, in terms of building the manpower and the workforce that is required to do this, to achieve this on the continent. Other initiatives like the African Stroke Organization, the Achieve, the WFNR and WCNR. Again, I want to acknowledge everyone that has collaborated in our NIH-funded studies, including Bruce himself, the commissioners, 322 commissioners of the Lancet, and of course the Lancet, including the editor, who has been very supportive. And finally, I want to thank SEQUINS once again for this rare opportunity to give the very first State of Science lecture on what we can do to improve brain health by joining hands together, by flying with wings, and then letting the pillar